Welcome to Physician Academy. Today we're going to speak about ACE inhibitors. ACE inhibitors are also, the long name is angiotensin converting enzyme inhibitors. They're a class of drug used primarily to treat hypertension. They're also used to protect the kidneys for diabetic neuropathy, to protect the kidneys from diabetic nephropathy. They treat left ventricular systolic dysfunction and heart failure, and they're a first-line agent for myocardial infarction. So the mechanism of action for ACE inhibitors, as the title says, in their name, they inhibit the angiotensin converting enzyme, which is in the renin-angiotensin-aldosterone system, or the RAS system, RAAS, which regulates plasma sodium concentration and arterial blood pressure. This takes place in the kidneys. Angiotensin I is converted to angiotensin II by the angiotensin converting enzyme. Angiotensin II is a potent vasoconstrictor of the efferent arterioles found in the kidneys. Constriction of the efferent arterioles increases pressure in the glomerulus and increases glomerular filtration rate. So we're blocking that enzyme, so it no longer converts it, and it decreases the pressure in the efferent arterioles. We'll discuss more about the renin-angiotensin-aldosterone system, or the RAS system, in a later talk about the kidneys. So what's a common ACE inhibitor? One of my favorite common ACE inhibitors is lisinopril. It comes in a 2.5 milligram, a 5 milligram, a 10 milligram, a 20, and a 40 milligram. It can be dosed as a daily single dose or as a twice-a-day dosing. The maximum dose is 40 milligrams twice a day. However, very little is gained in lowering the blood pressure past 40 milligrams per day. The 2.5 milligram dose is used on patients with normal blood pressure, and those patients that would benefit from having an ACE inhibitor as part of their medical therapy. So if you have normal blood pressure, why would you need an ACE inhibitor? Well, these are good to protect the kidneys in diabetic patients or in heart failure patients. The 5 to 10 milligram dose is used as a starting dose for patients that have a blood pressure in the 140s to 150s millimeters of mercury, increasing every 2 weeks to 1 month until the patient's systolic blood pressure is less than 120 millimeters of mercury. The 10 to 20 milligram dose is used for patients with a blood pressure of 150 to 160 millimeters of mercury. And again, you'd increase that every 2 weeks to 1 month until the patient's systolic blood pressure is lower than 120 millimeters of mercury. The 20 to 40 milligram dose is used for patients with a blood pressure greater than 160 millimeters of mercury. And you increase that every 2 weeks to 1 month until the blood pressure, again, gets to goal of 120 millimeters of mercury. Generally, it is a rare case that you can get more than 20 millimeters of mercury drop in the systolic blood pressure with the ACE inhibitor. So, when you're treating a patient, once you get 10 to 20 millimeters of mercury drop, you're going to need to add another dose, another medication. So, for example, if their blood pressure is 180, even as you approach the maximum doses, it's rare that you'd get a patient that would drop more than 20 to 30 millimeters of mercury. So if they came in with a blood pressure on average about 180, you're going to get them down to 160 or 150, and you'll still need a second agent. So once the maximum dose is reached and used continuously for more than 30 days, and if the blood pressure is not at goal, it's time to add a second medication. So what's a good second choice? Medication to add depends on the patient's medical problems, of course. The standard in the JNC8 would be to start with a thiazide diuretic or an ACE inhibitor. So if you've started with an ACE inhibitor this time, you would add a thiazide diuretic. And we've already talked about my favorite, which is hydrochlorothiazide. If the patient has congestive heart failure, you're going to add a beta blocker. That should probably be started in the beginning anyhow, the minute they have congestive heart failure. So a beta blocker is a good choice. Not recommended. You don't want to add an ARB because angiotensin receptor blocker, also known as ARB, is working the same pathway. So you already blocked this pathway as much as you can. So adding another medication to try to block along the same pathway doesn't seem to gain you much. in the terms of results. So you're just throwing two medications blocking the same pathway. The ideal is to find a medication that would work synergistically in a different pathway that involves blood pressure. So that's where a beta blocker or hydrochlorothiazide diuretic works. You can also use alpha blockers. These are all medications that we'll talk about in other lectures. Other examples of ACE inhibitors, we have captopril, dosed as a BID dosing, and we also have benazepril, dosed QD or BID. And if we look over the milligram dosings of each one, we get the same results as we do with lisinopril. The lower milligram dosing is used for, again, the same thing, for people who don't need much movement in their blood pressure, but would benefit from being on an ACE inhibitor like a diabetic or a patient with congestive heart failure. The higher dosing is used for people who have higher blood pressure. This concludes the talk on ACE inhibitors. It's a brief one, and then we'll talk some more about other medications, and ACE inhibitors will also be discussed later on in treatment of other diseases like congestive heart failure. Hope this is helpful.